Thank you, first of all, to everyone who's joining us here today, both our audience and our panelists. We're excited to be sharing about type 2 diabetes in this Lunch and Learn session today. So to kick it off, I'm going to introduce our moderator, and then he'll take it away. So Dr. Zane Gibbs holds a PhD in chemical physics from the VCU Department of Chemistry. And Zane worked for about over 20 years at Altria in a variety of roles, including research and product development, marketing, and strategic planning. But today, he is the CEO of Zada Strategy, a management consulting firm specializing in human systems for business. So thank you so much for being here today and agreeing to moderate this for us. I'm going to let you take it away.
Well, thank you so much, Madeline, for that kind introduction. I really appreciate it. As Madeline mentioned, my name is Zane Gibbs, and I'm the moderator for today's session. I'd like to begin by thanking the VCU School of Pharmacy for allowing me the opportunity and the honor to host such an important Lunch and Learn session on type 2 diabetes. It's a topic that's near and dear to my heart, as several members of my family have actually been diagnosed with type 2 diabetes. So I'm excited to not only be in the presence of our panelists, our expert panelists today to learn, but also I hope for all of you in the audience today, as well as myself, that we together learn more about diabetes. Hopefully we can learn some strategies to help avoid type 2 diabetes in our future. And if we've been one of those individuals who's been diagnosed with type 2 diabetes, we can learn how to better manage it. So again, thank you, and thank you for all of our panelists today. So let's begin by meeting this expert panel, a great group of people. I'm going to begin with Jeffrey Tingen. So Jeffrey, please introduce yourself.
Thanks, Zane. My name is Jeffrey Tingen. I'm a clinical pharmacy specialist at VCU Health. I currently practice in the Department of Family Medicine and Population Health, and kind of lead a program with chronic disease state management for patients in 2 academic family medicine practices. Prior to joining VCU last year, I was a clinical pharmacist at UVA Health in Charlottesville for about 5 years. And then prior to that, I was a faculty member at the University of Michigan College of Pharmacy, where I started my career for 4 years prior to that. And thanks for having me today.
Thank you so much, Jeffrey. That's great. Our next panelist is Haley Billingsley. Haley, would you please tell everybody a little bit about yourself?
Sure. I am also very thrilled to be here today. My name is Haley Billingsley, of course, and I'm a registered dietitian, clinical exercise physiologist, and PhD student in VCU's Kinesiology and Health Sciences department. My day-to-day role looks like working actually in a clinical setting with patients with type 2 diabetes, as well as in clinical trials also dealing with type 2 diabetes. So I've gotten very close to many of my patients, and it's an issue that's also near and dear to my heart.
That's great. I've got a new person I need to see down at VCU now. So John Bowhite is our last distinguished panelist today. John, would you introduce yourself, please?
Yeah, absolutely. And again, thanks for having me. I too am very excited to be here and ready to discuss a lot about diabetes. My name is John Bowhite. I'm an assistant professor here at VCU School of Pharmacy. And I've been here for about 5 years at VCU. And my main roles here at VCU related to diabetes are I co-coordinate the advanced diabetes elective, where we take a little bit more deeper dive and look at more of some of the newer initiatives for diabetes that are happening around the country. And then I also predominantly practice at a free health clinic, Crossover Healthcare Ministry, where I predominantly help patients who have diabetes and to help improve their health.
Wow, awesome, John. Awesome. Thank you so much. So, John, let's begin with you with just a very simple question, just to help us all get grounded. Can you tell us exactly what is diabetes?
Yeah, absolutely. Diabetes, it can be broken down into more simple terms or more complicated terms, depending on who you ask. But essentially what happens with diabetes is there's an excess amount of blood sugar or sugar in your blood. And this sugar comes from the food that we eat. So you may hear the term glucose, and that's typically how healthcare providers refer to blood sugar. But essentially those terms are the same. And when we eat food, especially foods like carbohydrates, which are foods that are similar to like pastas, potatoes, many different foods have them. These foods get broken down in blood into our bloodstream, and we have high amounts of blood sugar. Now, in people who don't have diabetes, our bodies make insulin, and the insulin takes the sugar out of our blood into the cells that need this sugar or glucose for energy. And as somebody who has diabetes, this process doesn't quite work. So we still have sugar that's broken down from the food that we eat, but unfortunately the insulin doesn't either work well enough, or we don't make enough insulin to get that sugar into the cells for energy that we need.
Wow, thank you, John. That's really interesting. I'd heard a lot about the correlation or the connection, if you will, maybe between diabetes and blood sugar, but never really understood it that way. So thank you. So Jeffrey, can you tell us, again, just for more background, I've heard this conversation about like type 1 or type 2. Jeffrey, can you tell us a little bit about what are these types and what does type 1 versus type 2 mean?
Sure. So we generally classify diabetes into two types, type 1 diabetes and type 2 diabetes. Type 1 diabetes is what we typically refer to as like insulin-dependent diabetes, and that's where basically your body is not making insulin. And that is typically done as a result of like an autoimmune process where your body is destroying the cells or destroying the process of making insulin. So because of that and having type 1 diabetes, you're required to take insulin injections in order to live and to function on a day-to-day basis. Whereas type 2 diabetes, what we consider generally is that the body produces insulin, but your body just doesn't use it the right way, or your body doesn't respond in the correct way. So even though you're making insulin, your body just can't use it appropriately. Your body then a lot of times will try to produce more, but it's not working in the right fashion to lower blood sugars. And so that's the reason why we kind of classify type 1 versus type 2. So definitely type 1 patients, sometimes you think about maybe at a younger age of onset, or sometimes juvenile diabetes or insulin dependent, whereas type 2 diabetes is more related to insulin resistance or not being able to use insulin appropriately that your body is making. And then we have treatments for that as well too.
Thank you, Jeff. Thank you so much. Haley, so you see quite a few patients. And as a nutritionist, I can imagine that registered dietitian, that you see people with type 2 diabetes. Can you tell us a little bit about what are some of the misconceptions that your patients may have about diabetes?
Sure, absolutely. Thank you, Zane. So first off, I apologize for not explaining exactly what I do. If you haven't seen a dietitian before, we are nutritionists. We help you change your diet to best benefit your health. And one of the most common misconceptions I see from my patients is a feeling of food fear and food shame. You know, I've done the wrong things and this is why I have type 2 diabetes, or I cannot eat these 35 foods ever again. And I guess first off, I don't want you to feel that way. You can still continue eating many of the foods that you like. It might be a great time to make some simple swaps, which somebody like a dietitian would be happy to help you with. One of the most common foods I hear people saying they can't enjoy anymore, especially in the summer, is fruit. So our blueberries, strawberries, watermelon, and for people with type 2 diabetes, often it's a process of just limiting serving size. So if you were eating maybe 5 or 6 slices of watermelon before, you might just need to limit it down a little bit. So that's where a dietitian can really step in and kind of see what you're doing now and modify it so you can still enjoy the foods that you love.
Yeah. Oh, that's awesome, Haley. I would probably myself fall into that camp of thinking, oh boy, did I make the wrong food choices? I can't ever have anything with sugar ever again. And what you're saying is that's not really the case.
Absolutely. We still want you to enjoy the foods you love. We just might need to change a few things around to make sure those foods love you too.
Great. Great. Well, thank you. John, have you heard other misconceptions around diabetes as well, beyond just the dietary things that Haley's mentioned?
Yeah, I mean, I think the first thing is that patients, when they receive that diagnosis for diabetes, they feel very negative, like they've done something wrong. I agree with much of what Haley has said. And that's not really the focus. The focus is not on things that patients have done. It's probably more of a system-wide issue. And many times I also find that even though diabetes has run in a family or from many family members have diabetes related to that patient, they don't actually know a lot about what diabetes is. So I do spend a lot of time at that first visit saying that you can live a long, healthy life. We can work on this together. And let me tell you a little bit about what exactly diabetes is.
Great, John. I think it's so important for us to, and you've mentioned it several times on the panel today, that people not thinking that it's their fault or something that they did wrong is super important here. I mean, it's just part of our body function. And Jeffrey, you talked about that body function earlier in your first answer. Could you tell us a little bit more about what actually causes type 2 diabetes? You know, we've said it's definitely not we're doing things wrong, but help us better understand what the actual causes are.
Yeah, so when we think about type 2 diabetes, insulin is a naturally occurring hormone, and your pancreas, an organ in your body, produces that hormone. And that insulin kind of helps in your body transport blood sugar or glucose from your bloodstream to kind of your body cells to use for energy sources. So when you have type 2 diabetes, your body kind of becomes resistant to that insulin, and it's not able to use it efficiently and use insulin efficiently to help lower blood sugars. And so therefore your pancreas has to start kind of working harder in a sense. Over time, with higher sugars and working harder, your pancreas kind of may get damaged a little bit, and eventually you're not able to use it as effectively. And so that's kind of how the mechanistic side of that type 2 diabetes causation is. In terms of what causes it, a lot of things we think about in terms of risk factors or things that may cause, like obesity is one that we consider associated with type 2 diabetes. Another thing, kind of like John mentioned a couple minutes ago, there is this potential genetic component and genetic link that, we may have family members in your family that have this predisposition that you may have type 2 diabetes as a result from the family history. That is sometimes harder for people to understand at times, simply because they may not know of anyone in their family. But the difference is, in the past several years, we do a lot more testing and screening because we realize how important diabetes management is for long-term health. And so you may have had relatives, grandparents that never actually got tested because it wasn't kind of the normal health maintenance and kind of like routine yearly physical exam and some of those things to actually get them tested and understand that kind of genetic history and that family history component to type 2 diabetes as well.
So Jeffrey and John, either one of you, so what are some of the signs that someone might have that lets them know whether or not they have type 2 diabetes? How would I ever find out?
Sure, I can jump in first, Jeffrey, if you want. And I may add on to the last question too about what Jeffrey said is it's a little bit complex because everybody is different. I think we really need to treat one person with type 2 diabetes may be in a completely different spot from somebody else with type 2 diabetes, and the underlying causes and risk factors really need to be taken into account as we try to individualize that treatment. So there's a lot we know about diabetes, but we can't always give you a definite answer on when things are going to progress, when things need to be adjusted. So we do need to keep in mind that even somebody who is type 1 or type 2 diabetes, within those patient populations, everybody's a little bit different in whether they've had diabetes for a little bit or a long time. So I think that's an important thing to consider. Some general symptoms I think most of my patients notice, actually they probably notice them a little bit more after their blood sugars are under a little bit better control than they were earlier, is frequent urination, frequent thirst, changes in vision, blurred vision. those are probably my top complaints for patients who are, or top issues that my patients discuss with me, because those are ones that they notice can get improved quite quickly with just a little bit better blood sugar control. There's many more. I can let Jeffrey touch on a few other ones if he wants, but those are the big ones. I see patients say, hey, I'm sleeping better. I'm not going to the bathroom as much. I don't have to run to the restroom all day. I feel like my quality of life has improved a lot.
Yeah, thanks, John. Other things kind of mentioned, a lot of times patients may present with fatigue or just feeling kind of run down and lack of energy for a period of time. And it's kind of hard because that's a non-specific symptom that can relate to lots of different things. Some others may actually have like dry mouth or kind of more dry skin. Another symptom sometimes people notice is vision changes, whether that's blurred vision or just kind of just vision's not kind of there where it used to be. And that can sometimes be a result of having diabetes and uncontrolled blood sugar as well too.
Hmm. And you know, I think someone mentioned earlier the idea of juvenile diabetes. Can you tell me a little bit more about that? And maybe is there an age component to diabetes?
Well, I think traditionally we've thought of type 1 diabetes as more of a juvenile component, and we do see type 1 diabetes occur at the beginning or diagnosis probably more frequently in younger populations, but type 1 diabetes can occur at any type of age. And type 2 diabetes, which we traditionally have thought happens more around middle age, has started to increase in even teenagers and younger patients. So there are some traditional ways we've thought about diabetes, but we're seeing that type 1 diabetes can be diagnosed across many different age groups. And type 2 diabetes is probably moving a little bit to a younger population or younger ages. As Jeffrey mentioned earlier, we're having higher rates of obesity in the United States as well. So that's been a big driver.
So Haley, we've been talking a lot about sort of the connection between type 2 diabetes and diet. Can you tell us what happens when someone eats and how, you know, the sugars in the food becomes sugars in my bloodstream, but how is that different from someone who has diabetes and someone who doesn't?
Sure, absolutely. So we have several different macronutrients, and macronutrients are things in food that contain calories. The macronutrient we think about most when we think about type 2 diabetes is carbohydrate. And that's because when we eat foods that contain carbohydrate, they become sugar in our bloodstream. And foods that you might recognize that contain carbohydrate could be anything from a starchy vegetable like a potato, down to fruit, as we discussed earlier, a banana, a peach, a plum, grains like rice or bread, and some other foods contain varying amounts of carbs as well. So when we eat these carbohydrate containing foods, they go into our stomach and then down into our intestines where they are absorbed into the bloodstream. In people without type 2 diabetes, our body responds with that insulin that I heard Jeffrey and John mention earlier, and that insulin is able to naturally control the spike in blood sugar after we eat. However, in people with type 2 diabetes, they don't have that same insulin response. So even if two people, a person with and without diabetes, ate the same thing, the person with type 2 diabetes might see a much higher spike in blood sugar because that insulin is not working to kind of put that carbohydrate away when we eat it. And as we'll probably talk about a little bit later, even within carbohydrates, there's kind of a different response in terms of the blood sugar spike we see in people with type 2 diabetes.
So Jeffrey, one question, since I'm learning so much from Haley about the connection between diet and so much from you and John about just the mechanisms, is it possible that someone could, for example, be diagnosed with type 2 diabetes and then have that condition either worsen and it becomes type 1? Can you sort of transition, if you will, between type 2 and type 1 diabetes? Jeffrey, is that something that can happen?
we typically don't think that you would transition between the two. If you're diagnosed as type 2 diabetes, we don't necessarily think you would all of a sudden have type 1 diabetes down the road. Where that sometimes I would say gets more confusing is like treatment options. So last time, like I mentioned before, type 1 diabetes, the mainstay hallmark of treatment is insulin therapy. Whereas with type 2 diabetes, we have oral options and other things, but some patients do require insulin in order to kind of treat their type 2 diabetes as well. But we typically don't think you kind of flip back and forth, only because that, like I said, that type 1 diabetes is more kind of an autoimmune kind of process mediated that your body's destroying, insulin that's being produced or not making it appropriately. So it's a little bit of a different kind of mechanism there between the two.
John, one of our audience members on Facebook asked us a question about a type 1 diagnosis, and that they had heard that you could be diagnosed with type 1 diabetes all the way up to somewhere around age 30. Is that true?
It gets a little bit, it's a good question. And there are the two main types of diabetes are type 1 and type 2. So about 5% of people with diabetes have type 1 diabetes. And the majority of people with diabetes have type 2 diabetes. The autoimmune response that can happen at any time in life. And there's also this condition that is referred to as latent autoimmune diabetes in adults. And this is sometimes referred to as type 1.5. So I don't want to confuse our audience members, but there is a type of diabetes that sometimes is referred to as type 1.5. So many times these patients can be diagnosed with type 2 diabetes because of their age and their initial response to oral medications. But eventually they have a gradual, it's a late onset, but a slower gradual increase in the antibody response that destroys the insulin producing cells in your body. So you can have this type 1.5 diabetes as well. It's pretty rare, but sometimes it gets overlooked in people who are diagnosed more at the age 30 or 40.
Interesting. So like you said earlier, diabetes is such an individualistic condition that it really can vary from person to person. But thank you. I think hopefully that answered the question for our audience member. So I'm going to open up a question to everyone, but John, I'll begin with you since you did such a great job with our last question. If I go in and have my blood measured and the doctor says, hey, your blood sugar level is a little high, you might be at risk for type 2 diabetes. A lot of people say, well, I'll eat a little less. Why should I care? It's not going to really put me at risk for any other things, is it? So, John, what's your opinion on that?
Oh, yeah, that's a great question. So there are various stages of where people are who either have diabetes, have complications, maybe from long-standing diabetes, who may one day have diabetes or have something called pre-diabetes. So there are a lot of different stages where people can come into the doctor's office. Our goal as a clinician is to help keep your blood sugar at a good level. And I think we do need to make sure when we're looking at these tests, patients are and their clinicians are knowledgeable about when did they eat food, because that can affect some of the tests. And then if they're doing some of the other tests, I think we'll talk about later, like hemoglobin A1c, that test tells you a little bit more, it gives you a little bit more data on how long your blood sugar has been elevated. So the bottom line is there's a normal level of blood sugar or a range that we like for our patients to have. And the higher your blood sugars, the more at risk you are for complications. The lower, and there's some caveats to it, but generally the lower or more normalized your blood sugars are, the less likely you're going to develop some of these complications. So there's some differences in whether you do that, managing it by lifestyle, activity, exercise, by medications. But in general, we want to keep it at a good level to prevent things like heart disease or kidney disease or eye disease from occurring. So even if your blood sugar is a little bit high, we don't want that to continue to progress to an area where it can get really high and start causing some problems down the road. So a little bit high is nothing to be alarmed on that day, but should be a little bit of a motivation to start kind of holistically looking about what are some things I can do to help improve that blood sugar number.
Oh, thank you, John. That reminds me of some things that my doctors told me and other family members that, just small changes early on can really have huge differences to your health in the future. So thank you. Jeffrey, we've talked a lot about the different types of diabetes. Can you tell me, how do we diagnose type 2 diabetes?
Yeah, so typically with the diagnosis of diabetes, I would say that probably three characteristic things we look at is blood sugar. So sometimes you may get fasting or lab work done before you've had anything to eat or drink for several hours. And if you have a fasting blood sugar, typically right now over the number of 126, we typically consider that diagnostic of type 2 diabetes. Another value that you may hear we diagnose type 2 diabetes with is an A1c or a hemoglobin A1c. And that we kind of consider that at a level of greater than or equal to 6.5%. The last one that's kind of most commonly that we use for diagnosis is that if you ever have like a random blood sugar, like at any time of the day, whether it's a fasting, you just ate, anything like that, and that blood sugar is, we consider kind of greater than 200, but also you're having some of those symptoms that John and I touched on earlier. So if you are having excessive thirst, excessive urination, some of those things with a high random blood sugar, that can also be indicative of type 2 diabetes. Sometimes we will check those labs on more than one occasion just to confirm the diagnosis, just to ensure, it wasn't a lab fluke or a lab thing going on that day or something just happened. But those are kind of what we typically consider how we diagnose type 2 diabetes based on a lab value perspective. One thing that you may have heard of or we've done that's kind of fallen out of favor, there is what we consider an oral glucose tolerance test. That's where you actually kind of drink like a bottle of kind of glucose, and we kind of check your labs periodically after that. That's kind of fallen in favor because not a lot of us want to drink that stuff because it's not the most tasty. However, we do still kind of use that when we're looking at kind of diabetes screenings in pregnancy. It's kind of like the more common way that we use it now for pregnant women. That's just something that is also out there too, but not typically in a routine day-to-day diagnosis. We don't ask our patients just to drink the glucose stuff just to get a diagnosis there, or to screen for it.
Yeah. So, I mean, it may be obvious to some in the audience, but maybe not. I'll just sort of recap what you said, Jeffrey. Is it all begins with just a simple blood test, right? You draw blood. Then you run various tests on that blood to ultimately determine, what the sugar level is in our blood. So it's a simple thing. It's not terribly invasive. So again, for those of you in the audience who are, don't know exactly how it's done, it's a very simple sort of test, right?
That's right. Typically, a small amount of blood or a finger stick. Just to kind of get a small blood sample to help that diagnosis there.
Great. So John, both you and Jeffrey have talked about this thing that I see on commercials, talked about quite a bit, A1c. Can you tell me what A1c is and how does that at all relate to blood glucose?
Jeffrey, you want me to take this one first or?
Yeah, go for it.
Okay, yeah. Please feel free to fill in anything. So an A1c test or a hemoglobin A1c test can be measured really easily, as Jeffrey mentioned, in the doctor's office. The nice thing about this test, it tells you what your average blood sugar has been over a 3 month or 2 to 3 month period. So glucose actually binds to your hemoglobin and it measures the amount of blood sugar on that hemoglobin. So the good part about that is it gives us a kind of a longer window of looking at what your average blood sugar is with that test. So it gives us a little bit more of a holistic picture as opposed to a finger stick in the office may just give you a blood sugar from that day that could be impacted by various factors. Maybe one of the downsides of the test is it tells you an average. So it doesn't mean that you're always at that blood sugar number. So typically we see most patients who are early on in their diabetes are going to be trying to achieve a blood sugar or A1c of less than 7%, which is equivalent to about a blood sugar of 154. Just because your A1c is 7% doesn't mean your blood sugar is always 154. It could be sometimes 100. It could be sometimes 180. So there's still a role for checking your blood sugars, but at least it gives us a little bit of better idea of one simple test can tell us what an average sugar is over a 2 to 3 month period.
So is there a situation where you could have high blood sugar levels or perhaps a high A1c level and it not be related to diabetes? Is high blood sugar and or a high A1c always an indication of diabetes? Either John or Jeffrey?
I can take this one. So I would kind of say yes. It's like the most simplified answer. So if you're experiencing an elevated A1c, and again, of course, if there's other, we always have those kind of caveats or kind of the individuals that may not fit the normal kind of criteria. But it's one of those things. If you're experiencing a high A1c, we're probably going to also check other labs to see like other blood work and those things like what your glucose is or those things. If something doesn't line up, that's when sometimes we may have to kind of go down the road of like identifying, could it be a lab abnormality? Do you have something where your blood cells may not be shaped correctly, so it's kind of throwing off labs, those kind of things? Those are very, very, and I say that very rare. It's not something that we would typically do unless there's other kind of caveats there. But typically we would consider if you have a high A1c, that is what we consider diagnostic of having diabetes. And so that's when we would kind of proceed forward with kind of the treatment options and those things to make sure we're controlling your diabetes in order to kind of improve quality of life and kind of prevent those complications of diabetes as well.
I can add to that. I agree with Jeffrey. It's a little hard to trick the A1c test unless you're having something going on in your body that's throwing off the test. If your A1c is high because your blood sugars are high, it means it's been high for a long time. Acute changes in blood sugars can happen even with things like medications or stress, but a lot of those patients already have underlying maybe insulin resistant issues, but something's driving up the blood sugars on top of that. So your blood sugars can go up maybe from a medication or infections can cause it in an acute situation. But your body is able to decrease the blood sugar down to where it was in an acute situation. But the A1c test is hard to trick because that's over a 2 to 3 month period.
So John, how often should I get my blood sugar or A1c levels tested?
Yeah, generally for people who have diabetes, we recommend if your A1c is uncontrolled, you should get it every 3 months. So we should check it 4 times four times a year. So every 3 months. If you have an A1c that's controlled and there's not any clinical suspicion or medication changes, you are given an option to check it less often, maybe every 6 months.
Okay. All right, great. So let's say that I've been diagnosed with type 2 diabetes. I'm one of those folks that has had that diagnosis. John or Jeffrey, can you tell me what are my care options available?
Jeffrey, you want to start on this one?
I'll start off first. Yeah. So kind of we alluded to this earlier already, is that this is a comprehensive approach when you've been diagnosed with type 2 diabetes, and so everyone kind of starts this process when you get that diagnosis about how uncontrolled those blood sugars are. Are you having symptoms that are affecting how you live your life? Like if your blood sugars are very high when you're newly diagnosed and you're going to the bathroom all the time and those things, we may want to be more aggressive in getting those blood sugars down just to make you feel better. Because we don't want you out there just like feeling not so great secondary to these high blood sugars, so we could do a more aggressive intervention to lower those blood sugars more rapidly. In terms of kind of general care options, we focus on lifestyle modifications as kind of a hallmark treatment, focusing on diet, focusing on physical activity levels, focusing maybe reducing stress levels, if that's another contributor there too. We also talk about medication management. Sometimes with those lifestyle modifications, it's not enough in order to help lower the blood sugar. So we have oral medications that we take. We have injectable medications that you can also take to help lower blood sugar. And then we also have insulin therapy as well too. And all of those can be used sometimes in combination, sometimes separately. But generally, I would say most clinicians, we kind of utilize a kind of a stepwise approach. We don't just throw everything at you at once. We try to kind of do a stepwise approach to make sure you're tolerating things. But ultimately, when we're sometimes having these conversations, one agent or one option from a medication standpoint may be more effective and help lower those sugars. And again, every clinician's goal, honestly, is just to get you feeling better as fast as possible. And if you're really having those symptoms and feeling crummy as a result of your diabetes, we want you feeling better to just enjoy life.
And I can add on to that as well. So that was a great overview for sure. We would like to think that everybody with diabetes who gets diagnosed has an A1c diagnosis for diabetes is 6.5%. So we'd like to think that everybody who gets diagnosed with diabetes just crossed that threshold and just became diagnosed with diabetes, maybe an A1c, between 6.5 and 7%. But sometimes we don't see people get diagnosed until their A1c is much higher, and they don't realize how they've been feeling for so long. So it could be, if you're not going to your regular scheduled appointments and you're not getting screened for diabetes, then that could be a potential issue as well. So yeah, I think Jeffrey's right. If your blood sugars are really high, we need to bring them down quickly to prevent you from feeling bad or ending up with other complications. On the flip side, if your A1c is more in that pre-diabetes range, which is 5.7 to 6.4% or under 6.5%, then you have some additional options. So Jeffrey already talked about lifestyle modifications. There are diabetes prevention programs. So you can actually, within a group, with lifestyle coaches, work together to improve your health, which is a great resource. And even if you do have diabetes, some clinics or offices have self-management programs too. So we really want you to be in control of your diabetes and have all the tools you need and all the educational resources to help manage your diabetes. And so looking out for those options, maybe a little bit non-traditional ones that we think about as well. And I think Jeffrey covered for sure all the treatment options. And I would definitely put a plug in having someone like Haley on the team to work with people to make sure that we can help develop a food plan that fits their lifestyle. So many people eat very many different foods, and finding a healthy food and lifestyle plan is really essential. So people like Haley, who are registered dietitians, are really crucial members to have on the team as well.
Well, yeah. So let's dig into some of these lifestyle modifications or changes just a little bit deeper. And you mentioned Haley, John. Haley, let's bring you in here and talk to us a little bit about diet and some of those dietary changes that we can make to either help us avoid or manage type 2 diabetes.
Absolutely. So when somebody is diagnosed as prediabetes, one of the first things we like to look at is whether they might be eligible for some weight loss. And I think either John or Jeffrey might speak about that in a minute, but that's something dietitians are typically very involved with. Usually with diabetes or prediabetes, I think of two things, how much are you eating and what are you eating? So maybe we'll stick with the what are you eating right now. I would say for each person, this is very individualized. So it's good to take a hard look at the carbohydrates you might be having in your diet right now. Now, I mentioned certain vegetables like corn and potatoes, which are considered starchy, and fruits and grains like rice and bread. Some of the big culprits in the American diet, which might push your blood sugar up a little higher and you might want to limit, are things like juices and sodas and other sugar-sweetened beverages. So if you're pre-diabetic or newly diagnosed with diabetes, you might really want to cut down on those or switch them for even better options like seltzer water or flavored water that has 0 calories. Maybe water with a squeeze of lemon or lime. So sugar sweetened beverages are a big one. You might want to look at the portion sizes of other carbohydrate containing foods that you're having and limit that to 1/4 of your plate at a mealtime. So what I mean by that is if you're having pizza for dinner, it might be a good idea to limit it to 1 slice if you were formerly having 3 slices, and fill the other half of your plate with a salad. And again, most of the things I'm saying are really applying to somebody who's been newly diagnosed with diabetes or is pre-diabetic. And so things like that pizza crust are what we consider refined carbs. So white bread, white rice, don't have to entirely cut them out if these are things you really love. But if you're newly diagnosed or pre-diabetic, it might be a good time to kind of cut back on the serving sizes. And I will put in a plug for the American Diabetes Association. They have some great resources, as it's very hard to mention the appropriate portion sizes of carbohydrate containing foods for everything across the board. So definitely go to the American Diabetes Association's website, check out some portion sizes for carbohydrate containing foods if you are dealing with pre-diabetes or newly diagnosed with diabetes. The last thing I'll say is it might be a good idea to start to slowly transition your diet into one of what we call a healthier eating pattern. So many of us have a Americanized or Westernized dietary pattern that's rich in fast foods, the sugar sweetened beverages I mentioned before, those refined grains like white bread, white rice, etc., and kind of start to transition into a fruit and especially non-starchy vegetable rich dietary pattern. So really filling up that plate with as many non-starchy vegetables like salad, broccoli, that kind of things as possible. So the Mediterranean diet and the DASH diet are 2 diets that I like to mention for people who might be either pre-diabetic or newly diagnosed. They can be really instrumental in helping you limit or choose really optimal carbohydrate containing foods.
Thank you, Haley. One of the, I think, most impactful things that you said, and then again, I'm reminded, I know you said it earlier, is that you talk a lot about moderation and changes. And, sometimes I've heard, you need to eliminate. And I suppose that's true for some people, I would imagine. But I think, what you've helped me understand, especially for those who may be in the pre-diabetes stage, that again, it's these small changes to your diet that can often make big differences. Jeffrey, John, just a question about that in diet. So have you had patients who have maybe implemented some of Haley's recommendations and just on diet alone, can you tell us how big of an impact that might have on someone's risk for type 2 diabetes?
Sure, absolutely. So I guess we can think about in 2 different ways. If you have pre-diabetes, we know that by exercising regularly and losing just 7% of your weight, you can help prevent diabetes. So you can lower your risk of developing diabetes. So 7%, we think of numbers, but 7% is not an overwhelming number, but that in conjunction with some exercise can really help prevent diabetes, lower your risk for developing diabetes. For those with diabetes, you can see differences in blood sugar control just by losing as little as 5% of your weight. And anecdotally, cutting out some of these foods that Haley mentioned, just in individual patients, yes, I've absolutely seen major changes in their blood sugars from visit to visit when they say they've really tried to make some healthy switches or decrease, not cut things out they really like, maybe cut back a little bit. I have seen some pretty major changes. And I find that those are the types of changes that people really get excited about when they see that they make a small change in their lifestyle and it makes a big impact on their blood sugars.
So Jeffrey, given what I've heard from both John and Haley, it makes me wonder, is type 2 diabetes a condition that can be reversed? Or if you've been diagnosed with type 2 diabetes, is there a cure out there?
So really, I would say, can type 2 diabetes be reversed? So we really kind of focus more on getting your type 2 diabetes under control. And that's kind of the key in treatment and trying to get your A1c to the appropriate goal for you, which is for most individuals to be less than 7. The one caveat in terms of reversal, I would say that, and this is somewhat controversial at times, but I would say the one thing that we sometimes think about that maybe could reverse type 2 diabetes is sometimes bariatric surgery or weight loss surgery. You know, we sometimes would think that if you have significant obesity and high weight, and you were to have weight loss surgery, sometimes we would say that we have seen that kind of resolve. But again, we don't necessarily, for a lot of the things, we have some longer term data now and information about that, but not always. But we really don't have, like, there's not a magic pill that's going to cure diabetes and those things we consider a cure or a magic thing to take. But we really kind of focus more on what's going to control your blood sugars to get them to a more normal level in order to kind of prevent you from having those complications that we alluded to earlier. So not really a cure, but more, we want to make sure it's controlled, is that what we focus more so on.
Thank you. So next question is for everyone on the panel. I might begin this one with Haley. Haley, you know, you've probably dealt with patients who themselves have type 2 diabetes, but also I would imagine, work with families. And so you, I think, know the importance of other members of the family or, you know, those who provide care, the role that they can play in helping someone with type 2 diabetes. Can you speak a little bit to that? What would you advise, say, someone who's supporting someone who's got type 2 diabetes?
Absolutely. So all of the changes that I mentioned earlier, these things like maybe cutting back or cutting out sugar sweetened beverages, you know, switching to a more healthy dietary pattern like the Mediterranean dietary pattern or the DASH dietary pattern, which are rich in things like whole grains, think whole wheat bread, brown rice, fruits, vegetables, especially non-starchy vegetables. These are good for everybody, not just people with prediabetes or type 2 diabetes. So what's good for the patient is good for the rest of the family as well. And coincidentally, you might be helping a family member down the road from struggling with this issue. So I would say, yeah, you don't have to cook a separate dinner for just one person. These food recommendations are helpful for almost anybody. Kids, adults, everybody can eat these healthy dietary patterns and kind of limit these foods that we find in the American diet, like those refined white, quote unquote, carbohydrates and sugary drinks. These things are just good for everybody.
Yeah, it kind of takes a village, right? That's kind of our advice here. Yeah,
it sure does.
Jeffrey,
if I can add to that, I would just say, and I think support by the family is important, but maybe finding, as I mentioned earlier, those diabetes prevention program options in your community. Many of them are held at YMCAs or your local churches. So you can get a lot of support and you can get a lot of that food education and working as a group to make yourself healthier. So even if you feel like as a family member, you don't have the skills, there are resources out there and groups that can help you get healthier too.
Thank you for mentioning that so much, John. I know that there are people in our audience for whom that kind of support could be very helpful. Yes, thank you. So, Jeffrey, you mentioned earlier there are a variety of medications or other drug interventions that can be used to help treat type 2 diabetes. Can we take a moment just to talk about a couple of those options, Jeff?
Absolutely. So I would say for type 2 diabetes, many of us are maybe familiar with a medication called Metformin. That is kind of typically what we consider one of the first line agents due to its kind of effectiveness and also kind of general kind of the way it reduces blood sugar. So that's one medication that we kind of generally most patients get started on right off the bat. From there, we have lots of other options that they work in very different mechanisms. So for example, metformin kind of helps to decrease, body's kind of production of sugar. We have other medications, and this has kind of grown some in the past 10 years or so. And so we have other medications that help your body make more insulin and kind of release more insulin throughout the day. That medications maybe like glipizide or Gladra, you may have heard of those. We have other medications in the oral classes that are newer that help you eliminate sugar through your through urination and basically through your kidneys to help you basically urinate out more sugar and to eliminate that in that process. We have injectable medications that can help, with decreasing appetite, helping your body release more insulin when you're eating meals and your sugars are rising up after you eat something. And then we have insulin therapy, and insulin therapy is there to kind of help provide your body external or outside insulin in order for your body to use it appropriately to lower the blood sugar as well too. Kind of the rundown of a few of the drug classes that we have out there, each with their own kind of dosing strategy, how often to take them, some of the different side effects as well too with them as well.
So, John, let's say that I am someone who is taking one of these drug interventions, say an oral or an injectable. How important is it that I take those medications in sort of the regular way in which they're prescribed?
Yeah, I think first off, we want to develop a medication regimen that works for you or for the person with diabetes. I mean, that's the most important thing. So we always want to develop something that a plan that is going to make everybody successful. So we are interested in clinicians of hearing things like, I'm really busy at this time of day, or I work non-traditional hours. Those things are always important factors in our decision-making process. I would say the part of the reason why it's important to take medications regularly is each time your blood sugar goes up, you do run that risk of developing some irritation in the body or some light, I don't want to say damage, but some just from the high blood sugar, it's going to irritate the body at that point. So we're trying to minimize that amount. The problems with diabetes come from when you have elevated blood sugars for long term, but even short periods where your blood sugar is high could have a little bit of effect. So the other thing is you're going to feel a lot better if you take your medications, and that's probably the most important thing. Having a blood sugar going up and down may not make you feel great on a day-to-day basis. So those are some of the things I talk to my patients about.
And Jeffrey, with patients who are on medication and have been diagnosed and are on medication, how often should they be measuring their blood levels to determine whether or not the drugs are working?
Yeah, so in terms of managing your diabetes and checking blood sugars at home, that is really, I'll be honest with you, a very individualized thing you need to discuss with your clinician who's managing your diabetes. For some individuals, we may have you test once a day, first thing in the morning, to get like a fasting blood sugar when you haven't eaten or drinking for several hours. For other individuals, you may need to test multiple times a day just to kind of make sure you're not having those highs and lows. And if you are, so we can kind of tailor treatment options to that. For some individuals, you may not be asked to test at all, period. And so that it just depends upon what your regimen is, where your diabetes management is at, how uncontrolled you are or how controlled you are, and what that looks like. The other thing that's kind of picked up a lot of steam the past few years, we also have what we consider continuous glucose monitors, where you actually can wear a sensor on your body for a period of time, sometimes a week or 2 weeks. And that gives you the option to continuously measure your blood sugars kind of in intervals whenever you may want to with a reader. And so everyone's different in kind of what treatment you're on may guide how often you need to test your blood sugar. And sometimes that's kind of the way that works. But it's really important to ask, if you're being asked to test blood sugar, make sure you're getting specifics from your clinician to say how often, when exactly. Because my biggest thing with testing blood sugar, pricking a finger, it's not pain-free. It's invasive. And so my biggest thing is if you're going to spend the time and you're going to test your blood sugar, it should be valuable and value added to your treatment plan. And you want to make sure that we're going to do something and your clinician's going to do something with those blood sugar numbers to help guide treatment. Otherwise, you're pricking your finger maybe the wrong time, or it's confusing. So make sure you get really good clarity about when they wanted you to test to help guide treatment options there and management.
Awesome. Well, thank you. Thank you, Jeffrey. So in our last 5 minutes here, I just want to take a moment to ask a question from the audience that I thought was not necessarily what we had intended to cover, but I think really important. And the question is, we've talked a lot about high blood sugar levels, but can you also talk about low blood sugar levels and, tell us a little bit more about that as well? Maybe Jeffrey, we'll start with you.
Sure. So a lot of times with diabetes, we focus on high blood sugars and getting these blood sugars down, but there are actually quite a few risks and dangers with low blood sugars. Low blood sugars can also put you in the hospital as well, and this is a safety concern. A lot of times we think about low blood sugars, or when sugars may drop kind of below 80 and 70s in those lower marks there. That sometimes happens as a result of getting over medicated, or you're in medication treatments and you may not be following a balanced diet, or hey, you got busy and you forgot to eat a meal or skipped foods for the day and those things, and all of a sudden you can get in trouble with certain medications and treatments there. The biggest thing with it is just making sure you're looking out for the signs of low blood sugars, like feeling shaky, dizzy, sweaty, extremely hungry, like you could eat anything in sight, confusion. And if you have any of those things, don't ignore them. And that's kind of one thing, like, oh, just something, oh, it's going on, I'll play it off, I'll just give out my day. You want to try to check your sugar if possible. And then you want to treat that low blood sugar. And I'll kind of punt it over to John to kind of talk about treatments for low blood sugar as a segue to him.
Yeah, thanks, Jeffrey. Patients sometimes, or the people I work with sometimes, get a little bit more scared with low blood sugars than they do with high blood sugars sometimes. So it can be a scary feeling where you're feeling shaky. If it gets really bad, you may feel like you're going to pass out. Your heart's beating fast. You're feeling sweaty. This is also another good time. That may not be a regular time that you usually check your blood sugar, but anytime you feel bad and you have diabetes, you probably should check your blood sugar and make sure your blood sugar is either not too high or too low. Typically, I think it's a good idea for people who have diabetes, if they do test their blood sugar, it's below 70, then they probably need to ingest a little bit of something with carbohydrates in it to bring up that blood sugar. So we usually counsel people on around 15 grams of carbs. And what can that be? It could be a half a cup of juice. They make glucose tablets. It could be a lot of different things. You want to actually consume some carbohydrates at that point. What you don't want to do is drink a big, large size soda to bring up that blood sugar. You want to drink a little bit of amount of sugar, around 15 grams of carbs, or eat, and then check your blood sugar again in 15 minutes to make sure it's come up. And then at that point, you may need to eat a little bit of some additional food just to sustain it so your blood sugar doesn't go down even more. And so that's a tricky thing that we sometimes work with our patients about, to try to avoid that situation, but also have the tools to manage that situation too. Some people get symptoms at different levels of lower blood sugars, as Jeffrey mentioned. So some people don't have any symptoms of low blood sugar until maybe they pass out. So there's a lot of different situations that can happen. So having access to blood sugar testing, having family members who are knowledgeable about what happens if your blood sugar gets too low is important. And then the last thing I'll mention is there are a lot of different new medications out there for people who have extremely low blood sugars. So if typically patients who had extremely low blood sugars, which may cause you to pass out or become unconscious, there is an intramuscular injection that we could give you to bring up your blood sugars. Well, the patient who has diabetes can't do that to themselves because they're unconscious. But now there's new formulations, there's subcutaneous injections, which are similar pin formulations to how people inject insulin, or even a nasal spray that you can use now too. So a lot of different options. The goal for us is to keep you away from getting as many lows as possible. But if this has happened in the past, there are more tools to help prevent it getting too low as well.
Well, thank you, John. So in our last minute, I'm going to ask each of our panelists, I'll begin with Haley. If you had one piece of advice for someone who was either pre-diabetic or dealing with type 2 diabetes, what would that one piece of advice be? Haley?
Absolutely. There is so much misinformation out there, and I think it is just so essential to have a care team that includes a physician and a pharmacist like John or Jeffrey, as well as a dietitian. And if you can't find that combination at your local doctor's office, the Diabetes Prevention Program, as John mentioned earlier, is a great resource to get that pharmacist and dietitian support, especially here in Richmond, where we do have a specific diabetes prevention program that combines the two. So that would be my main piece of advice.
Great. Jeffrey, how about you?
My piece of advice would be just make sure you ask questions. This can be very overwhelming to patients, so ask as many questions as you need to ask and find someone you're comfortable with. Sometimes you may need to go to another member of the care team or a specialist for this. But this is something that's typically a lifelong thing you're dealing with. So make sure you feel comfortable with who's managing this. And that's what's going to help you be more successful down the road.
Great, Jeffrey. And then John, how about you?
I think that's some excellent advice that we just heard. Both those I would completely agree with. And I would just say, don't put things off and go ahead and start trying to get information and try to make small changes. We don't expect, and you should not expect yourself, if you have diabetes, to fix everything at one time. It is a process. And I usually tell people, I'm going to see you a lot at the beginning to make small changes. And then hopefully we see each other very less frequently, maybe once or twice a year, to check in on how things are going. But at the beginning, we're going to give you lots of information and tools to help yourself, allow you to make some lifestyle changes. And if we need to make some medication changes, we'll make those along the way. But don't feel like you have to do everything at once. It's a process. And so go ahead and start making some small changes. Don't feel overwhelmed that you have to make everything change right at once.
Great advice, team. Well, I would like to thank all of our panelists today, John Bowhite, Jeffrey Tingen, and Haley Billingsley, for all of your awesome advice. I have learned a lot. I feel so much more educated after this session. And, I feel like I've come away with a couple of real strategies to help me, and I think the audience has as well, to help them really understand what the causes of type 2 diabetes are, how we could better manage it if we have that condition, and ultimately how we avoid it in the first place. So I really appreciate your time today. You guys have been a great panel. I'd also like to again thank the VCU School of Pharmacy for having this very informative lunch and learn session, and again allowing me to be your moderator. And thank you to all of those who are in our audience today. We appreciate your questions and we appreciate your time. Thank you very much.
Yes, thank you all panelists and audience. We appreciate, like Zane said, we appreciate your time. And thank you again, Zane, for being here to moderate for us. You did an excellent job. And I think we all could have talked a lot longer on type 2 diabetes and some of the ways to manage it. But we hope that we've answered your questions, and that you'll tune in next time come fall when we host our next Lunch and Learn. So thank you all again for your time, and have a great rest of your day.